Good morning. Is that any better? Can you hear me? Okay. Should I turn it up?
Yeah.
Great. Thanks for the feedback. Okay. Good morning. It's good to see all of you here. When I submitted this workshop, however many months ago we were supposed to do that, it seemed like a really great idea. And then I didn't hear anything. And then like a week or two ago, I got a notification that the time for my session changed. Which is when I realized I was going to be giving this talk at this conference. I probably missed an email. So that's, I'm sure, on me, not CCHF. But yeah, so the limits of self-care, reclaiming or reimagining an ethic of communal care is what I hope we can talk about today. So I get a little bit nervous speaking, so I'm going to try and speak slowly so I don't get in a hurry. I feel the need to add a couple of disclaimers at the beginning. A friend at the beginning of the conference said, "Oh, are you doing a workshop?" And I said, "Yeah, I'm doing one on Saturday." And she said, "It's not going to be the one where you have to like talk to people and like a workshop, because I'm not coming to that." I want to sit in the back and just listen. So disclaimer, there might be some conversation or interaction. So if you feel the need to either prepare yourself or find a more suitable session, you're welcome to do that. It won't offend me. My other disclaimer is, I don't know why everyone's here, and maybe we can talk about that a little bit. But if you're hoping for like 3 simple strategies or tools to take away and not be burnout or when you return to work, this is also not that session. I don't think I can offer that for you, but I hope that we can at least start or continue some conversations about how to care for each other in this community. So a couple of introductions. I'll share more of my story later, but my name is Chad Thompson. I'm a family doc. I currently work in Waco, Texas. I have a joint faculty position at Waco Family Medicine residency program. Yeah, all right. We have 3 of our awesome residents here. And so I get to spend some time with them in clinic and teaching. And then I also work at Baylor University. So I get to work with undergraduate students and pre-health students as they kind of think about their journey and how they want to serve faithfully in the world. And that is not what I imagined I would be doing when I came to this first conference 11 years ago, but that's where I am now. Since 2015, I've worked for CCHF clinics. I was thinking about it, and I think technically I've worked for some length of time, 5 different organizations that intersect with CCHF. And so I've seen the world of CCHF in a few different spaces. I spent a lot of time thinking about formation of students and healthcare practitioners and those who are kind of this next generation who are really discerning a sense of calling and what that means. And so that's kind of frames a little bit about why I wanted to talk about how we care for one another as we are caring for others. But it's helpful for me to know who's in the room. So how many in the room are involved in like direct patient care in some way? Nursing staff, clinical staff, you're at the bedside or in the community taking care of patients in some capacity. Okay, great, that's the majority. How many are maybe in more administrative or managerial or leadership roles where you might do some of that, but you're more distant from like the actual bedside? Okay. Okay, so that's a smaller percentage. And then who didn't raise their hand? We have students in the room, lots of students. Well, a lot of students, great. It's because you're already burnout, or hoping I can help you get to the next step. I'm glad you're here. How many of you, this is your first conference? Okay, so pretty representative, close to half. How many have been working at a CCHF clinic or organization sort of setting for more than 5 years? Okay. More than 10? More than 15? Okay. So several people who've kind of had some link that, and how many of you that was all for the same organization? Like you've been in one place, okay, good. How many have been with the organization you're with since its beginning? Like from the time that organization started, you've been there all the way through? Only two maybe? Okay. So anyone else who's working for a CCHF organization, you entered into this story after it was founded. True? Okay. Okay, good, that's helpful. All right, so I want to do a little bit of a grounding exercise. This might be more for me than it is for y'all, but you're welcome to join in as you feel comfortable. But I would invite you to sit all the way into your chair, sit all the way down, where you can really feel the chair beneath you supporting you. You can feel the back of the chair or the wall or wherever you are, as comfortable as you can be with your feet flat so you feel the ground beneath you. If it's helpful to close your eyes. And if you can, take a few slow, deep breaths, slowing your breathing down. And as you breathe, I'm going to offer some words from Psalm 63. O God, you are my God. Earnestly I seek you. My soul thirsts for you. My body longs for you. In a dry and weary land where there is no water. And as you slow your breathing, I encourage you to breathe this scripture. So I'll kind of cue you on breathing in and out as we read the scripture again. So take a deep breath in. O God, you are my God. Breathe out. Earnestly I seek you. Breathe in. My soul thirsts for you. Breathe out. My body longs for you. Breathe in a dry and weary land. And out where there is no water. Take a few more slow breaths. All right, so let's bring it back together. So I want to talk this morning, as I mentioned, not so much about solutions to burnout or feeling overwhelmed or tired, but more an invitation to a conversation about the kind of people that God is calling us to be. But we will use this concept of self-care as a a starting point for conversation. So some of the goals of this time, I want to outline the history of the concept of self-care, talk about some of the history, where it comes from, how it's evolved, how it's commonly used today, specifically in the context of healthcare. Let's talk about some of the benefits, limitations, and maybe unintended consequences of self-care being a dominant framework or response to burnout. What is burnout? By the way, can someone, like when you hear burnout, like what does that mean to you? It's a word that gets used a lot. Like I feel it's become almost kind of like common language for like, I'm feeling burnout. Loss of energy, okay. What else?
No reserve.
No reserve.
Yeah, so loss of energy with no reserve.
Like, you're out of energy and there's nothing to draw from.
Yeah.
Running on empty and there's no gas station. What was that? Apathy, meaning like a loss of like purpose or motivation in what you're doing. Okay. So not just energy. You can have a low energy or be drained for many reasons, and that may not fully capture what burnout is, but maybe there's a component of I'm indifferent to the things that once I felt purpose in. Okay. What else? Pervasive. Meaning, who said that?
Maybe work or out of work. You come home and it continues. You don't have energy and it seeps into other areas.
So it's something that affects all domains of life potentially, not just I'm burnt out at work, but I have this feeling all the time, everywhere, at home, family. It's affecting beyond just one domain of life.
Over expenditure to the extent of adaptive shutdown.
Okay, so you're overexpending to the point of adaptive shutdown, meaning like that's, would you explain that a little bit more, adaptive shutdown?
That it's a appropriate response, or it's an expected response.
Yeah, so this feeling of like shutting down might actually be your body's appropriate response to what you're experiencing. Okay. Anything else? Yeah.
Sometimes worked out.
Okay, so sometimes the way burnout is talked about is it names or directs towards individual agents within a system that might actually be contributing. We'll talk about that.
Comment on the adaptive shutdown. It's something that I thought of when you were talking about, when you're burnt out, you don't have the ability to adapt and switch and pivot. You don't look for solutions the same way.
Right. So you lose some of your ability, of your resources. Often people use the word resilience, this ability to bend and flex back. I want to just name even the word resilience, but burnout, like, I don't think that's me. What? Oh, no, it's okay. I was like, is that coming through the mic? So what else burns out? Candles. What? Fire. Light bulbs. Wires. Rockets. Machines. Engines. So I want us to just note this language around burnout. Like the burnout actually often, it's a more mechanical term, which I think we should note because we're not machines, right? But if we name our experiences as, there's something about drawing on language of burnout that kind of has this mental map that we are machines that shouldn't burn out, and when we do, we should fix it in some way. But we're not machines. And we need to talk about that. And even the language that we use to describe our experiences, we're borrowing from kind of an imagination of like how we're supposed to operate and exist in the world as machines to be optimized and restored and functional and productive. But we're human, we're creatures, we're created with limits. And so we're gonna draw on that a little bit. Even the idea of resilience, like what does that term mean? It's like the property of how far can you bend something before it breaks? It's how resilient it is. How far can you bend it and it still snaps back into position? It's also mechanical We're not machines. So burnout is a concept. The definition that I use, I think, of emotional exhaustion, depersonalization, meaning this feeling distant or not recognizing yourself, or a loss of like sense of who you are in the work that you're doing, or kind of a going through the motions. And then this reduced sense of personal accomplishment or purpose. So you can be exhausted and overwhelmed, but feel like what I'm doing is purposeful and meaningful, and you can sustain that in ways that you can't when what you're doing means nothing to you anymore. There's a difference there, right? So that's part of that concept of burnout, and this depersonalization, feeling like a loss of sense of self. So this kind of shows up as cynicism and kind of jaded language in the ways that we begin to speak and act and see the world in ways that this isn't who I am. Like that's a component of burnout. But all three of those are usually present. But for the sake of this conversation, we can use the framework of burnout, but you can also use these other separate or related terms like moral distress or moral injury, where you're making decisions or being forced to make decisions in a reality that aren't in line with what you know is what's best. Either I can't do what's right for this patient or in this scenario because of certain constraints, and over time that does something to you. Like I know the right thing to do and I can't. Or because of resources or constraints or pressures, I'm doing something that I know is not the right thing to do, but it's my only choice here. Both of those result in moral injury, which is a separate concept for burnout, but really important to talk about. In the work that we do, many people experience moral injury. In healthcare more broadly, but also in the settings where we work. It's very prevalent. One day I would maybe potentially like to actually study that and think about how we're responding to that. But maybe you just want to use the whatever term you're going to use to describe the feeling, I can't do this anymore. And maybe that's why you're in this room. I don't know. And maybe this is too ambitious of a goal, but I really want to continue a conversation about what it might look like to practice communal care rather than simply self-care as a response to some of these issues. We are CCHF, so we are a community who cares for communities, and so it is part of how we think and how we imagine care. But in our caring, how are we caring for each other? How can we have this conversation across generations, across a diversity of roles and positions and disciplines and expertise, across a diversity of experiences, life experiences and backgrounds, across stage of life? I think we each have something to offer in this conversation and things we can learn from each other's perspective and journey. Many in this room have been in this work for a really long time, and many are entering into stages of work at different points in that journey for the life of an organization. And I think that matters in how we experience this together. I'll name some of my limitations. I'm just one family doc who's only not even 10 years out of residency. I don't have a wealth of experience or knowledge here other than my own that I can offer to you, and maybe offer you some of my own story and wounds as a place we can have a conversation. So the challenge, why even have a workshop like this? The work we do is hard. Why else would we have a theme of fear not with a scary monster in the background? Whatever your feelings are around that, there's a reason why that would even be an idea for the theme of a conference. The resources and sometimes the labor seem few. How many of you have ever showed up to work and you've been short-staffed? How many of you worked a day where you haven't been short-staffed? Maybe that was a better question. How many of you have ever had to take on a role or responsibility that you didn't actually sign up for when you started? How many of you that temporary arrangement became more permanent without any sort of negotiation because you just had to, or felt like you had to? Okay. Who sees staff turnover in their organization as something they're concerned about, something you think about, it comes up, okay? Either because how many of you are experiencing that, like that's an active concern, okay? How many of you are thinking about it because you don't want that to be a concern? I hope you're thinking about it. Okay, great. So we've come down from the peak of COVID for physician burnout. It was around 63% in 2021. It's still more than like 45%. It's really high, just the daily experience of being burnt out for physicians. For nurses, that number is closer to 70%. We don't talk about that as much, but I think we need to talk about it. Physicians aren't the only ones who are experiencing really hard things in healthcare. There's a study that 1 in 5 nurses plan to leave by 2027. For social workers, the lifetime prevalence of burnout is 75%. There's a lot of ideas about how we should approach this or respond to this, but over the past few years, really since COVID, I've heard more and more discourse about self-care as the response. We need better self-care plans. How many of you have talked about self-care in your organization? Or had to do some sort of training or module or webinar or something about self-care? Okay. How many of you would say you have a solid self-care plan in place that you can refer back to, like, this is my self-care plan? How many of it, like, it exists at all? In your head, at least. I have a self-care plan. Yeah, I've done the mental exercise. I know what a self-care plan is. Okay. What does self-care mean to y'all? Like when I'm saying that, what do you actually have in mind? What's on your self-care plan list? Self-kindness. So a perspective or maybe kind of dialogue towards yourself that's kind and compassionate, practices that help you practice kindness towards yourself, okay?
When I started off, it was manicures, pedicures.
Manicures and pedicures.
Yeah. You know, you got to realize that it's also setting self-limits,
Okay.
limits, and learning how to say no.
Okay, learning how to say no. Good. But maybe sometimes it's a manicure, massage, you know. That could be self-care too.
I would say intentionally planning, like and committing to spending time doing things that I need to do to be okay.
Okay,
That's usually getting enough sleep, getting enough water,
okay, good.
reading my Bible. Those are really good.
Yeah, good. So protecting your time around the things that you want to prioritize for your health and well-being. One more.
For me, it was learning that selfish behaviors were actually necessary.
Oh, okay. So we can maybe talk about that a little bit. So this idea that selfish behaviors, I'm curious in that, like, who is determining that that's selfish? Is that you or other people? Selfish behaviors might be okay, or behaviors that it might be thought of as selfish. Last one, yeah. Hitting the pause button. So taking a pause, taking a rest, taking a sabbatical. Okay, so we'll talk about that too. Good. There's a lot of different perspectives on how to address this, or even what self-care entails. And so I want to talk about some of the history of self-care and kind of walk through what it's come to mean. So WHO, World Health Organization, defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of a health worker. You got that? The ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of a health worker. Okay? What it is not is individual acts of self-interest or self-protection. Okay? There's a little bit different. Okay. But practices of self-care, as maybe looking at that former definition, have really existed across lay and popular and professional health arenas throughout history. So let's talk about self-care as communal practice. So before the professionalization of medicine, the maintenance of health took place in the home and in the community. It was relational. The trust, an individual's trust in their community enabled people to contribute to the health of their local community and population without relying on a healthcare system to do that for them. Even ancient professionalized traditions, so traditional Chinese medicine or Galeno Islamic medicine, even then they had instructions for professionals, but also for the lay community of how to maintain and think about health. But we have when you look historically, we have the scientific revolution and then the Enlightenment, and then we have the arrival of 19th century modern biomedical medicine, which brought in this really powerful cultural shift toward hierarchical and specialized knowledge that was concentrated in the hands of experts. And you can contrast that with self-care, where knowledge was in the hands of everyone and practiced and shared widely. And it was dependent on social support to actually carry that out. It also served as a tool during European colonization with its assumptions of scientific authority to overshadow indigenous practices and responses to illness. There's a whole history with how our current medical system was designed and has grown in ways that in some ways has undermined communal practices of self-care across cultures and traditions. For all of the good that's come with it, we can also name the harms that have come from that in the ways it's disrupted communal wisdom and practices of care. So essentially, self-care, as that first definition, it's becomes second. First, you need a professional, and then you rely on the other things that sustain you. So that kind of shifted with the rise of medicine. Then we have self-care as a resistance movement. So as that was happening, you have this increasing power of healthcare institutions. So I'm thinking about 1950s and 60s, so 20s, you have the develop of health insurance, at least hospital insurance. 1930s, you have the development of Blue Shield, so preventive care and clinics was developed. Then in the 50s, that was written into the tax law in the US that employers weren't going to be taxed for offering it as a benefit. So there's this whole history of how there's an increasing power of healthcare and how it's administered and paid for through insurance. And what that has done is in some ways disempowered communities to care for their own health, but it's also distanced practitioners from being present to the communities in which they're serving because of payer systems. So you have private systems that now has created this barrier between the relationship that happens here. And then in the 60s, you have the rise of public insurance. Medicare and Medicaid are created. And so now you have this public bureaucracy that is also doing the same thing, where physicians once saw caring for the sick, those who are sick and poor, as just something we did, even if they were uninsured, to know that's the realm of the public sector. So in some ways, with all of the good that we have with public insurance, there's a challenge there, and that it's created this distance and fragmentation of how care is imagined. And so in the 1970s, self-care and dialogue around self-care kind of surges this resistance movement to modern medical institutions' role in disempowering individuals to caring for their own health within the context of their community. This is probably most notable in kind of the body sovereignty movement, empowering women to understand their bodies, morbidity risks, self-care in pregnancy and childbirth, and a very male-dominated healthcare complex. So you see self-care language rise again in the 70s for that reason, as resistance to how the healthcare system was changing things. And in the 1980s, the WHO came out with another declaration. And it said that public policies in support of self-care must function to demystify healthcare, creating enabling environments in which people can more readily promote their health and care for themselves during illness. Some of you may be familiar with the community health worker movement and really thinking about how do we empower workers and peer support community health workers in communities. Some of that was a response to how our healthcare system had begun disempowering communities in some ways to care for their own health. Then the last kind of movement I want to talk about is the commodification of self-care. So contemporary healthcare is increasingly unaffordable. It's focused on high-tech acute interventions. It's dependent on highly specialized systems. And so the need for self-care now arises out of essentially systematic and institutional failures in existing medical communities for people to be able to access care at all. So now people have to return to self-care practices because they can't afford it, or the systems are too complex. Self-care is a necessity for some. I think of all my patients and all the remedies and the things that they have tried before seeking care because they can't afford it. I think it's also important to note how in medical training I was implicitly and sometimes explicitly taught to largely dismiss cultural healing practices as inferior or unhelpful. At least the ones that weren't evidence-based or delivered by and reimbursed by our healthcare system. Those were the ones I was taught to kind of dismiss, which again demonstrates the power of our biomedical institutions and structures that we built. Others who have means can choose. And so self-care essentially is, if I want to seek professional healthcare, that's a self-care option that I can choose, but not everyone has that choice in the same way. So with these increasing technologies and changes how services are delivered, healthcare becomes, so you have this change in how technology in some ways allows healthcare to become more accessible, but not for everyone. You also have this kind of pervasive culture of expressive individualism and a fraying of social and cultural institutions as well as public goods. So when you have that like combination together, self-care kind of becomes about individuals becoming active and autonomous decision makers for their own health with or without a health worker. And for the wealthy and privately insured, and you have this kind of capitalist self-optimization version of self-care where you purchase the things that help for your own wellness. But for many of the people that we serve, self-care almost becomes weaponized in a way where patients are labeled non-compliant, or there's this idea of a moral failure. Well, they're not doing all the things that we know promotes good health. They're not eating healthy, they're not exercising this many minutes a week and all these things, but without paying attention to the realities in which people are living. I know you're in this room because you think about these things. I'm not saying that we're dismissing that, but this is a reality of how self-care operates. But I want to be careful on how I think about self-care for my patients, where I'm not piling on blame on individuals. I want to think about these things. And then the last thing I want to talk about is this movement in thinking about self-care for the healthcare worker. We'll talk about the benefits, limitations, and some of the unintended consequences. So there's this US study in 2017 looking at clinical social workers. 41% of them met criteria for PTSD. And there's a study at National Association of Community Health Centers in 2022 that 68% of health centers lost up to a quarter of their workforce in the preceding 6 months. 15% of those lost 25 to 50% of their workers in the past 6 months. So this high turnover in community health centers. We looked at a small qualitative study in New York that was across different disciplines. High stress from staff shortages, coworker conflict. All of these were sources of stress for why people felt burned out or wanted to leave. Most of those surveyed had knowledge of and engaged in self-care practices. And many of them discussed the lack of support from their organizations to actually do those practices. So there's this rise in talk about self-care for those who are working in healthcare, particularly during COVID. It's this idea that, we need to put on your own oxygen mask before you it makes sense. You want to be healthy, you need your health to care for the health of others. So we're urged to have self-care plans. Are you exercising, eating well, taking breaks, practicing mindfulness, taking a vacation, praying regularly, reading scripture, going to church, all of these things. But let's talk a little bit about what's helpful about that. There are studies about the benefits of how self-care practices can be helpful in ameliorating burnout. That emotional exhaustion, the depersonalization, reduced personal accomplishment. Self-care practices are helpful. Maybe you've experienced ways that when I do these things, that is helpful. But there are some limitations. So there's a study in Australia in 2021 that looked at the advice during the pandemic that healthcare workers got to practice self-care to improve their mental health. And there are about 5,600 participants, and it talked about their disruption in their usual self-care practices because of the stress of the work. And the uncertainty of changes coming magnified that struggle. So they already weren't really feeling like they can practice the things they need to stay healthy, but then there's also this looming uncertainty of, I don't know what changes are coming. Maybe you felt this in your organization. Like, I just took on more, but there's not really like a plan, like, well, what are we gonna do? How do I can't keep doing this. So it makes it harder and harder to actually do the things you know to be helpful. But what was most important to be able to practice self-care in that study was that social connectedness was what was needed in order to actually practice self-care. And so once that loss of social connectedness, once that's gone, then it became really difficult to actually use any of the tools that they had to care for their health. So when this is lost, self-care gets reduced to an individual act of self-preservation or self-optimization to increase productivity or to maintain work-life balance when we lose the social connectedness and the trust of a community. The other problem is to think about ourselves as these autonomous, independent agents. Like, our concept of autonomy in medicine, I think, affects this. Like, when y'all think of autonomy, what does that mean in medicine?
Self-determination.
Self-determination, informed consent, non-interference, and patient choice. So this idea that we are like independent, autonomous agents, and even how we treat it in medicine, I think shapes how we think about our own autonomy. But what if we thought of autonomy more as relationally constituted, meaning like, I am because of who we are. I am because of who my family is. I am because of the community that raised me. I am because of, right? Like, none of us are actually independent agents who came to where we are because of our own efforts, and like, we don't actually exist as individual. Like, we become who we are because of who we are. Does that make sense? So part of our problem is when we think about self-care and autonomy is we're not thinking about the self appropriately. We don't think about ourselves as belonging and relationally constituted and supported and cared for. We think of, well, I just need to do what I need to do to get to the goals of whatever I have set out for me. In the same way we talk to our patients, what are the patient's goals and how do we help them get to, like, we've lost that even for ourselves. Okay. So I want to talk about some of the unintended consequences. And I'll be honest, I've been really nervous about this session because I want to speak honestly and be heartfelt, but I don't want people to think that I don't want, for those who are like looking for a really hopeful word or tool, and I can't offer that, I want to hold both of those things, and I don't know why everyone's here, but I want to talk about some of the unhelpful ways. I don't get a list of why you sign up for this session, so I'm doing my best with what I know. So this is just like the ads that you've seen for self-care. Like, you need this energy drink, not this one. Like, if you do these baths, you'll increase your dopamine, and like pay for this yoga thing and this fitness plan, and finally pooping on a normal. Like, this is kind of like what the market has made self-care. Some feminist scholars have offered some really helpful critique in the way that self-care has been co-opted by neoliberal governments who really depend on regulated citizens who can take self-responsibility and not depend on others for care. And the market is heavily invested in supporting burnout healthcare workers to continue their productivity. And so Like this is the commodification of self-care. This is this idea that if I purchase the right products, and like there's a market for that. And it causes us to become even more atomized and individualized. If I just purchase the right things and work harder to have the resources to do those things, it isolates us even more from depending on each other for the support that we actually need to be fully who we're supposed to be together. It's not wrong to like get a massage, but we have to pay attention to the market forces and the incentives behind wanting us to use our money for these things instead of sharing our resources freely in a way where everyone can flourish in our communities. So self-care must be located in the social domain, not just in the individual purchasing of products. All right, so some of the unintended consequences. So there's a way in which language around self-care, I've experienced this, where I'm feeling overwhelmed and burnout, and I'm asked about my self-care plan. When you feel overwhelmed and you're this shutdown, there's a way that talking about self-care can actually make you feel even worse. Like, you're right, I should be working harder. I should have had a better plan. I should be waking up earlier. I should be. When self-care is our go-to tool for people who are past the capacity of being able to engage there, 5 minutes, 10 minutes, okay, great. All right, we'll move a little bit faster. Especially in kind of moralizing language, like you should be doing these things, that can crush people even more into this burden when they're already feeling overwhelmed, even if those practices could be helpful. But when you don't feel like you can engage, it's hard. When you layer on that in a community like this, there's a deeper spiritual risk, I think, here. When Christians who are burnt out or experiencing moral injury, and then someone maybe very well-meaning might ask, well, but how is your prayer life? Or are you reading your scriptures? Have you not been to church? Maybe some of y'all resonated with that. And that can be well-meaning. We do want to be engaged in spiritual practices. But when you feel like you can't, and then someone is asking you why you're not, then you feel this added layer of kind of spiritual shame, or that this is a spiritual failing or moral failing on my part. It's because I don't have enough faith. It's because I'm not praying enough. Maybe you are praying and you're just not hearing from God right now. That's a really hard place to be. And we need to be present with each other and not critiquing our lives in this way, instead of just joining each other in presence. The other is distraction. Like if we focus on the individuals who are burnout and individual self-care practices to sustain it, then we can be distracted from the systemic realities and the organizational structures that are causing people to feel burnout in the first place. What we know is like the kinds of practices you need both individual practices and rhythms, but you also need organizational support. If y'all went to Esther Kim and Catherine Moore's talk about joy building, like they talked about the difference here. Like we need both of those things in self-care. And if self-care is the only tool that we offer without system and communal support, then those individual acts of like withdrawing and self-protection look like, well, I can't work that many hours. You're drawing boundaries that you want to be helpful, but it's in a way that withdraws, where then others are taking on more. It becomes really, really challenging. Like, how do we make decisions without just withdrawing? And eventually, if we don't provide communal support, we shouldn't be surprised when someone's self-care plan is to leave the organization. I think we should be honest about that. And there's another challenge. There's a study on really high work-related stress, looking at frontline family service providers who are witnessing and responding to substance use, interpersonal violence, homelessness, mental health struggles, concerned about safety, budget cuts, and understaffing. Any of this sound familiar? Yeah. High administrative load, mandatory trainings, poor support at work. The accumulation of this over time led to burnout and job turnover. 90% of workers in the study reported feeling general feelings of stress and anxiety, and they had self-care practices that they were using. But what they found was there's this curvilinear reality that the more stressors you have, the more people engage in self-care practices, until a point when they couldn't anymore. And so there's this curvilinear point where like there's a point where self-care is helpful and then you can't engage. There's also been studies in poverty around people who have access to resources to help have an avenue out. It's the same curve. It's a parallel curve. People who have no barriers are not likely to engage. People who have a couple might until there's too many barriers and you can't. And all the participants in the study had the same exposure to guidance about self-care. So it wasn't about knowledge or the tools or the education. It's just how we think about our ability and agency within the systems to act. All right, so ethic of communal care. I hope you'll hear me that practices of self-care can be really helpful if they're situated within an ethic of communal care. If we had another hour, I would tell my full story. But I was on a journey, went to residency at a CCHF site that closed in my third year, and we all lost our jobs. I moved to another state to finish residency. My wife was kind of left alone without her community because she was still finishing residency in the town where we were. I worked there for another year while she was finishing, and then we moved to another CCHF clinic where we worked for another 4 years. And right as we moved, there was a series of organizational changes that were really challenging. And some of the leaders have shared about that, like how it was really hard for leaders. And then a pandemic happened. Things that we could never have anticipated. Our family pursued the adoption journey through that, and we had 2 kids that joined our family, and we sheltered in place with 215 months in a new city and a new job. And both of my wife and I work in healthcare, and we kind of ground through that, thinking, all right, we can push through this. We'll come to the conference and get re-energized. And there's other people who've done hard things. We can do this too. But the reality is we burned out, and we needed help. We needed help with our kids. And we got to a point where we couldn't even see what we needed. And we felt really isolated. Even though we had some community, we didn't know how to express what we needed. And that was really hard to look back on and realize we didn't know how to be together as a community and support each other. And I thought we actually had really good community. We had great colleagues and some community outside of work too, but it was still really hard. And so, CCHF is the community that helped me stay in medicine and find a deep sense of purpose and calling, but it's, I had breakfast with Dr. Perkins as a medical student, and it changed my life. And I'm really grateful for that. But this is also the community that works really hard, and you won't work in this kind of space without experiencing some wounding, maybe some really severe wounds. So how do we care well for each other when we're wounded? There may be some of you, 3 years ago, I came to the conference. It was about 3 years ago, and I was planning my exit from medicine. I was done. Wasn't sure I'd ever come back here, if I'm honest. So for those of you who might be in that space, like, how do we think about caring for each other when we're at that point? There's a few things that I thought about. One is belonging and being known. When was the last time you truly felt seen by someone in your organization? Think about it, write it down. When did you truly feel seen? And when was the last time you felt like that from a leader or someone who's not on your immediate team, who's maybe more distant from you? When did you really feel seen and known? Wendell Berry has this great speech that's also captured in an essay, Health is Membership. And he says, I believe the community, in the fullest sense, a place in all its creature, is the smallest unit of health. And to speak of the health of an individual is a contradiction in terms. We must imagine our health as community. We belong to each other. I've been thinking about John 19, the crucifixion. There's this moment when Jesus is on the cross. He sees his mother and the disciple whom he loves. And he says, woman, here is your son. And to the disciple, here is your mother. And in the suffering of Christ, he looks and reminds them that they belong together. And if you notice, he doesn't actually use their names. It's his mother and the beloved disciple. Like, it's anonymous, I think, because we can put our names in there. And even when we're participating in the sufferings of Christ, in that suffering, we belong together. And Jesus is calling us to belong. Sabbath is a corporate practice. So there's been talks here about Sabbath and rhythms. It's a chance to remember that we are not what we produce. So I think of the Exodus story. God's people had been reduced to what they can produce for the Egyptian empire. More bricks, less straw. And God liberated them from that because he said, that's not who you are. And so he sends them out into the wilderness, and they spend 40 years there in a desert where there's nothing. And they wish that they went somewhere else. They wish they could go back. Their worth was no longer tied to production, but they were recipients of God's daily sufficient grace and sustenance. But on that seventh day, they couldn't gather more. Everyone had just what they needed. So it was one thing for God to bring his people out of Egypt, but it was an entirely different thing for God to get Egypt out of the people. They had to reimagine, reorder their lives and communities to trust in the God of abundance. So sometimes I wonder about the language that we might use about building the kingdom of God and advancing the kingdom of God. In what ways might we be still operating under the same logic? Of that what we do and produce for God's kingdom is where our worth lies. What if we just thought more about what it means to bear witness to the kingdom of God, where it doesn't rely on us to build it and secure it, but we can bear witness in the ways that we are God's people, in the way that we care for each other, where we have rhythms of rest, where we see each other as beloved children of God and not what we can accomplish for him. And then finally, corporate lament. So what does corporate lament look like? There's a reason why so many of the Psalms are Psalms of lament. And there's a time for rejoicing, but for people who are weeping, we need to be able to weep together. And not so that we can get to the rejoicing part, like so that we can cheer people up more quickly. We're not trying to find an efficient path out. There is a path out, and there's a path out together, but there is also time to have spaces of lament. There was a time where that's all I could read in scriptures, and sometimes I couldn't read it, I could only listen to it, because I just couldn't even read. When you're at that point, who's sitting with you reading? Or maybe who's reading it over you when you can't read it for yourself? What kind of community would we have to be? And I'm curious what other ways, what are communal practices that you've experienced, that you've thought about? How are y'all doing this where you are? And are we out of time? I think we're out of time. Like 1 minute, 2 minutes, okay. I'm sorry. My hope is that you will have some time to think and maybe have some conversations with people. Like, what does it look for us to be the type of community that cares well for each other? When people are wounded and maybe can't even name or see what they need, how are we with each other in that? When we moved to Texas, when we left the work we'd been doing, we went to move with family to rest. I stopped doing medicine for several months. And I felt like a failure, if I'm honest. I thought we'd abandoned our post, that we had lost our sense of calling. Maybe we hadn't prayed enough or done the things we were supposed to do. That's a really lonely place to be. And maybe some of you are at that point or have experienced that. You're not alone. I hope that you'll find a space to be able to care for each other here. And if that's you or you've experienced that, I would love to talk to you. In fact, if you want to send in the chat or send a message through Huva, if this is a conversation you want to keep having, I'm hopeful that there's spaces we can continue to create across generations, across roles, to think about how do we care for each other. The last thing I'll say, when we moved, I just was really disoriented. I didn't really know what we were doing. I didn't know where to go from here. We hadn't moved for a job or the next thing. We just moved to the safest place we could find and to live with family for a little while. And I met with a priest, not Catholic. It's a long story. And we went to lunch, and he heard maybe 5 minutes of our story, and he started to talk about Christian responses to injustice and to evil. And he said, there's 3 ways that Christians can respond. We can retreat and use our resources to try and distance ourselves from the suffering of the world. That's a really common response in Christianity. We said, that's not really a faithful response, and I know that's not what you want. We can also charge ahead to defeat it in anger, righteous anger. And he said, but anger is a limited fuel source. And in the process, it will burn you up and burn everyone around you. And that was what was happening to me, because I was angry about the injustice of what my patients and my neighbors were experiencing in COVID in 2020. It was burning me up. And I wanted people to be mad about it and do something. But he said the third response is actually the only way to sustain it, and it's through sorrow. Because sorrow, though it feels like it will overwhelm you, it cannot destroy you. And in the place of sorrow is where we actually draw near to the one who is acquainted with our sorrows, and it's there that we're not alone. And so if we do not create spaces to actually move through sorrow, we won't be able to continue this work. We have to name it and be present to it, not to fix it, but to commune with the one who gave his life for us to show us how to live and to offer us life. Not just the resurrection. We have all of Jesus, which includes his suffering. Okay, I went way over time. That was not, I didn't give as much time for conversation, but I hope if you want to have some conversation, if you'll send a message through Uva, and leaving with this question is, what does it mean to care for each other well? And can I offer a prayer as we go? God, the one who's acquainted with our sorrows, the sorrows of our communities, the one who entered into the pain of the world to show us how to live, be our healer. God, show us how to be present, to care and love each other well, so that people will know that we're your disciples. They'll know because of how we love each other, not because of all things we can accomplish for you, but by our love. So help us to love well. Give us the courage to love well. In Christ's name, amen.
Yeah.